Good evening, everyone, and welcome to our blood cancer Q&A event with Dr. Mehta. Thank you for joining us this evening. My name is Carrie Callis, and I'm the Director of Programs and Research Grants Administrator at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cancer Wellness Center. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. This event tonight is made possible in part by the David Wortman Memorial Fund. We are proud to partner with the Cancer Wellness Center, and Savina will now introduce herself as well as the center.
Thank you, Carrie. Welcome, everyone. My name is Savina Chacheva, Program Manager at the Cancer Wellness Center. The center is a nonprofit organization that provides free services to anyone diagnosed with cancer, as well as their loved ones. The center services include education programs like the one this evening, support services such as individual, family, couples, and child counseling, as well as support groups. We also offer wellness services, including yoga, mindfulness, stress reduction, and much, much more. Currently, most of our services are virtual, and to get connected to services, please visit our website at cancerwellness.org. As a reminder, you will be muted throughout the evening, and I ask that if you keep your video and audio on mute. If you're not sure how to do that, you can use the chat and send me a message. Again, my name is Savina privately, and I can help troubleshoot some of those issues for you. We will be sending a program evaluation post the session. If you could take 2 minutes of your time to complete that, we appreciate any feedback. And as also a reminder, the program will be recorded, and a recording will be sent to everyone after the program is ended.
Great, thank you. So at this time, it is my pleasure to introduce Dr. Mehta. Dr. Mehta is the Shea Family Professor of Myeloma Research at the Northwestern University Feinberg School of Medicine and the Director, Stem Cell Transplantation and Cell Therapy Program at Northwestern Memorial Hospital and Robert H. Lurie Comprehensive Cancer Center. Dr. Mehta is a friend of the Foundation and has generously given of his time and expertise at various Foundation educational events. We are so grateful to have him with us this evening as he's volunteering his time to share his expertise with us. And with that, I would like to turn it over to Dr. Mehta just to share a few opening remarks, and then we'll launch right into your questions.
Hi, everyone. Good evening. Thank you, Carrie and Savina, for organizing this. It's always a pleasure to participate in events organized by you and help patients in whatever way possible. It's a misty evening here on the lakefront, although the window at the back looks like it's sunny, but that's a little trick with the exposure. The COVID situation has obviously affected people's ability to go and see their physicians, go and get their treatments, go and get their regular monitoring done, and so on, tremendously. And as a result, people's worry and stress levels are very high. So I think this program is very timely. A number of the questions that we have will address issues to do with COVID, infections, monitoring the disease, new advances, and so on. And my hope is that it'll allay some of the anxieties that people have about the current situation and the monitoring of their disease, their treatments, and so on. Before starting, I'll just mention about the very preliminary exciting data that came out on the Moderna vaccine yesterday, where they were exploring 3 doses of the vaccine in 15 patients in each group. And every single individual, all 45 of them, developed antibodies to the SARS-CoV-2 virus. Now, bear in mind, this does not tell us that the antibody is protective. It simply shows that the vaccine stimulated an immune response. And at the two lower dose levels, 4 out of 15 patients in each group, or individuals, rather, they are healthy volunteers aged between 15 and 55, were tested for so-called neutralizing antibodies. And neutralizing antibodies are expected to be protective. We don't know where they are, but when you add those antibodies to a petri dish, if you will, with virus colonies, it inhibits the growth of the virus and kills them. So one would expect those to be protective. So the 8 individuals who were tested for neutralizing antibodies all had neutralizing antibodies that were functional. So I think those data are very encouraging, and although we need much more information, when there seems to be a huge cloud hanging over all of us in terms of what are we going to do about this virus, I think the important thing to bear in mind is that some super bright minds and lots of financial resources are at play trying to address this, and we will overcome this virus. And until that happens, all of us have got to be very careful. So, having said that, maybe we can get started with the questions that have been submitted.
Perfect. So we'll start with questions about COVID-19, as you started off talking about. The first question that was submitted, and we're going to start with the pre-submitted questions that people provided during registration, and then towards the end, the last segment, we'll do some live questions. So as Savina said, feel free to submit them via the chat function, but for now, we'll focus on the pre-submitted ones. What are the tests to determine if someone is immunocompromised, and what are the results of those tests?
So some of the tests are very straightforward and objective. So for example, one can look at the immunoglobulin levels, IgG, IgA, and IgM in the blood. That is very commonly tested in patients with myeloma, Waldenstrom's macroglobulinemia, CLL or chronic lymphocytic leukemia, and some types of lymphoma. It's not tested in some of the other hematologic malignancies, but that gives you an idea of what the humoral or B cell mediated immunity is. It's a measure of the antibody levels. You can also look at the T lymphocyte count, specifically the subset of T cells called CD4 cells, and that gives you a measure of another dimension of the immune system. Certain types of immune responses are more important for some infections, and others are more important for other infections. Commonly, one thinks of neutrophil count, which is not strictly speaking the immune system, but it is absolutely a measure of the defense mechanisms of the body. And if the neutrophil count is more than 1,000, the likelihood of being susceptible to infections that neutrophils protect against is low. And when it drops to less than 500, that risk increases gradually. What one cannot measure that readily is the functional status of the immune system. Sometimes the counts may seem fine, and yet an individual is susceptible to infections. They could be on medications that could potentially suppress the function of these cells. So, for example, bortezomib or Velcade, Kyprolis or carfilzomib, these are drugs that can inhibit T cell function, and the T cell numbers might not look bad, and yet patients are susceptible to certain viral infections like shingles and so on. So the best way to deal with it, and this is going to be a recurrent theme, is going to be to discuss it with your physician and ask. The numbers are helpful, especially if you are not on treatment. The numbers are helpful, but one has to be a little guarded if one is on treatment.
Great. What level of quarantine do you recommend for people diagnosed with blood malignancies?
Oh, it's a very tough, very touchy, and a very broad question. Um, I tell my patients that being completely quarantined and being a hermit is obviously the best protection against any kind of external infection. But you cannot live life that way. And one has to accept a certain level of risk in socializing and so on to live life normally. When one is dealing with a hematologic malignancy, a blood cancer, stem cell transplantation, and so on, do you think sitting at home all alone and watching Netflix and reading books is going to get us through? No, of course not. You need the companionship. You need to be interacting with people and so on. So I think the mere presence of a hematologic malignancy makes an individual more susceptible to infections by a small amount. And as the intensity of the treatment increases, the level of immunosuppression and compromise increases, and one has to be more and more careful about coming into contact with people who are unwell. Uh, so, ignoring the SARS-CoV problem at the moment, let's say there is a patient with chronic myeloid leukemia (CML) who is on one of the drugs. I'm going to mention Bosulif since there are questions about Bosulif later on, who is well controlled. Uh, can that patient live life essentially normally? Absolutely yes. What about a patient who has just had a mismatched stem cell transplant for acute leukemia and has just got out of the hospital a week ago, and he's taking some steroids for graft versus host disease? That individual represents the other end of the spectrum and is probably best off not coming into contact with anybody other than their closest circle that is required for care, including physicians and medical providers. And then you have the entire gamut in between based upon where you are in the treatment, what the diagnosis is, and so on. The key thing to bear in mind is that even without the COVID situation, hand washing has always been the single most important way to prevent infections. It's felt that 80% of community and hospital transmitted infections can be taken care of. This, of course, excludes things like fungus and so on by cleaning one's hands regularly and avoiding touching the face. Paradoxically, I find that our patients that we have educated over the years very stringently about these precautions have found the COVID situation far more easy to put up with, because for them, it's either what they've always done or it simply involves a 10, 20, 25% increase in the amount of care they take. It's the otherwise healthy, normal people on the streets who have found this prohibitively difficult, because for them it involves a complete change in lifestyle. So the level of quarantine depends upon the diagnosis, depends upon the therapy, and depends upon what the activity one is trying to engage in is. I try to not go to very crowded functions and certainly to a cinema in the winter, because I have no control over who is there in the theater with me. And Because the movies, I don't think that there is any movie that can not wait until it's available on TV or on Netflix. And if there is an important meeting, like a patient conference that I just did, I think about 3 months ago, I would go there because it's critically important. So I think there are multiple dimensions that one has to look at to decide what level of self quarantine to impose.
Great. Is there any data on how lymphoma and leukemia patients respond to the newly approved drug therapy for COVID-19?
So the only approved drug, the emergency authorization drug, is remdesivir, and we have multiple clinical trials of remdesivir. I have absolutely no personal experience at all, but I've had patients who have received remdesivir. I know at least a couple of colleagues who have received remdesivir, and they have responded. So healthy people and people with malignancies are expected to respond to the drug in an identical fashion. I think what dictates recovery from a COVID-19 infection is what the general health of the individual is, what kind of supportive care they are receiving, what, to some extent, what the status of their immune system is. And it's a little counterintuitive, and I'll come to that. And then what access they have to different drugs. There are certain drugs which have become incredibly politicized, as we know. But the drugs for which there seem to be interesting data are remdesivir, famotidine or Pepsid, hydroxychloroquine, and azithromycin are very controversial. IVIG may have a role to play, and a whole bunch of cytokine counteracting drugs which are used in autoimmune diseases like tocilizumab and so on have been shown to reduce the inflammation in the COVID-19 situation. So that brings me to the interesting point that people always ask, what is my susceptibility to getting the COVID-19 infection? So in fact, it should be a two-part question. Acquisition of the infection is one thing, and how the individual or their body deals with the infection is a second thing. So people with compromised immune systems, older individuals, and so on, are certainly more susceptible to getting the COVID-19 infection. But unlike a lot of conventional viruses, the thought is that a lot of the damage to the body and organ problems occur because the body mounts an exuberant immune response to the virus. And it's that battle that the body gets caught in. So paradoxically, patients whose immune systems may be slightly suppressed, either because of the disease or because of the treatment they are getting, maintenance therapy for myeloma, for example, may actually have a reduced risk of organ damage and life-threatening complications and so on. This is very general, it's not a rule, but that's our observation based upon the data that are available. Obviously, the best way to deal with this is to take all appropriate precautions to avoid getting infected in the first place. So I think the key thing to bear in mind is that more than the underlying disease, it is the overall situation, including the treatment, that makes a very big difference to the outcome of patients. In a larger place, and I'm going to mention Northwestern, University of Chicago, where there are literally 150, 200 patients with COVID at any given time, and where there is this vast amount of intellectual resource available. I think there has been a lot of acquisition of knowledge in terms of how to best deal with this, and the outcomes are better. At Northwestern, I can tell you that the ratio of deaths to discharges is approximately 1 to 20. So amongst patients who are hospitalized for COVID infections, the mortality rate is about 5%, which is extraordinarily low given the seriousness of the situation. And I think it is to do with the experience.
Dr. Mehta, are there any known cases of COVID-19 in patients with CLL, and how do they compare with other patient responses to the disease?
I don't know specifically about CLL. We have certainly seen it in acute myeloid leukemia, certain lymphomas, myeloma, and so on. And we have had no discernible pattern in terms of the underlying disease affecting the outcome. I think it is a big picture, just like I mentioned in my answer to the previous question. So I think an individual with CLL need not be more alarmed. Now, having said that, I will mention that because of the nature of the disease and the nature of some of the treatments, a patient with CLL might be a little more prone to acquiring the infection because of the immune system being compromised. And yet, perhaps based upon the type of treatment they are getting, they may be a little bit better off in terms of not having problems from the infection. One of the drugs that is used for CLL, Imbruvica or ibrutinib, there has been a clinical trial and it's being explored in COVID-19 infections. Now, I will warn you that the fact that a drug is being explored in a COVID-19 infection in a clinical trial is absolutely no guarantee that the drug is effective, because unfortunately, a lot of companies have seen this as an opportunity and a gold rush, and a whole bunch of small companies have put their molecules and drugs into clinical trials. And there are literally several hundred compounds being tried. And I suspect that at least 95, if not 99% of these things are going to turn out to be pretty useless.
So we have a participant that shared that after 2 years of treatment of Rituxan a year ago, what do they need to do to protect themselves from COVID-19? I'm not sure if these different treatments you'd have any different answer on how to protect yourself beyond what you said at the beginning about, some basic protection measures.
No, I think those protection measures apply to everybody. But one of the unique effects of Rituxan is that while it doesn't affect the T cells, unlike bortezomib or Velcade, Kyprolis or carfilzomib, it depletes the B lymphocytes that are partially responsible for making immunoglobulins, the IgG, IgA, and IgM I talked about. So often there is prolonged immunodeficiency or so-called hypogammaglobulinemia after Rituxan therapy. So, I think if one had Rituxan for 2 years and it concluded a year ago, it's fair to expect that the immunoglobulin levels, especially IgG, may be on the low side. And if it is dangerously low, then the susceptibility to not just COVID, but other infections may be a little higher. And the way to find out that would be through checking immunoglobulin levels. And in individuals whose immunoglobulin levels are very low, CLL, lymphoma, myeloma, and so on, sometimes getting infusions monthly of a blood product called IVIG or intravenous immunoglobulin is very helpful. It's an expensive treatment. It's also in short supply often because it's essentially a blood product, and therefore it's important that it's used only in patients who are likely to benefit from it, which is either very low IgG levels or repeated infections and so on. So that is something worth considering. And although IVIG is a very non-specific shield against somebody with a compromised B cell immunity, it's interesting that it may have some protective effect even in COVID. There are clinical trials going on, and because of the multiple effects that IVIG has, including on chemicals or cytokine reactions within the body, it may have a non-specific beneficial effect. We have a number of patients who get IVIG on a monthly basis along with their maintenance therapy, and I always tend to think that they are slightly better protected than patients who are not getting IVIG.
Persons in remission from multiple myeloma, but due to the virus not being able to go in for maintenance since the beginning of March, when should that patient start to worry about relapsing when they're usually scheduled to go in twice a month?
That's a very, very good question. When this COVID thing broke, our initial instinct was to avoid getting patients in for multiple reasons. We didn't, without knowing much about the virus and what we could do about it, and just knowing the data from China, we didn't want people coming in because they could get exposed to each other, their immune system could go down, and they could acquire an infection that could be potentially life-threatening. So we canceled people's maintenance therapies wholesale, thinking that this is not going to last long. But as it started lasting longer, we started thinking about it a little bit more critically. Do we ignore the danger that faces a patient, which is their malignancy, in this case, myeloma, and it's a clear and present danger, in favor of a virus, which is risky as it is, to some extent is a theoretical problem. So what we have done is, we people who missed maintenance therapy in March, we gave it in April. People who missed it, who did not take it in March, but there was a concern about April, we did not give it in April. And I think in May, we are giving it to most patients. And my expectation is that unless there is a problem, from June onwards, we will give it to everyone. We have had situations where patients did not come in because they were very worried about getting exposed to infections, and danger signs of relapse were missed. We had a patient who refused to come in when I wanted the individual to come in to be monitored because of a very tenuous situation. And the person was terrified about one clinic visit, did not come, and then had a massive relapse in a way that actually required hospitalization, when an early diagnosis of the relapse could have averted the hospitalization. So I think it's important to keep a watch on things. It looks like this person now has missed at least one and likely two maintenance treatments. And well, I'm sorry, 2 months of maintenance treatments. If it's two a week, they've probably missed at least four and possibly five. I think it's time to go in and get checked out and see what's going on.
So we have a question from an oncology RN working right here in Chicago, who is diagnosed with T-cell ALL in April 2019. She's been out of work the past year and was supposed to return to work in April, but her return date's been pushed off due to the outbreak. She's in the maintenance phase right now, and wonders if it's realistic or safe for her to return to bedside nursing before there is a vaccine.
Certainly, going to a COVID unit is out of the question. Um, Even a non-COVID general medicine unit could be difficult. Nursing is a profession where I think there is the greatest exposure to risks and the potential for infections and so on. The treatment of T-cell acute lymphoblastic leukemia is going to compromise the T-cell mediated immunity severely. It is going to compromise the B-cell mediated immunity severely, likely leave you exposed to bacterial infections as well. So I think a return to general nursing is difficult. Return to something where one could get exposed to COVID is prohibitively risky, and I would not advise it. If it is feasible, then I think temporarily an administrative position or an educational position may be worthwhile. But once again, I think this is the kind of situation where measuring the immunoglobulin levels, measuring the CD4 count, ensuring that appropriate prophylactic medications are used, like sulfamet, antifungal, acyclovir, or something like that, to prevent reactivation of shingles and other herpes viruses, is going to be critically important. As of course is going to be masks and hand washing and things like that, which one does in nursing all the time anyway.
So shifting gears a bit to treatment questions, how important do you think it is to seek a second opinion regarding the treatment protocol?
Great question. Um, in theory, one would like to have a second opinion for every single patient, but in practice, it is not possible because of logistics. Experts might not be available, insurance coverage might not be available, it might be in a different city, and so on. So I would say that if the diagnosis is completely straightforward and the prognosis is as expected, perhaps a second opinion is not essential unless you can go down the street to get another opinion. You are diagnosed at North Shore University hospitals and you want to come to Northwestern or University of Chicago for a second opinion, easy enough to do. If you are, down in Peoria or the Quad cities, to come to Chicago for a second opinion for something that is completely straightforward might not be worthwhile. But if the situation is complex, if one is dealing with a disease where the prognosis is likely to be grim, the treatment is likely to be complex and challenging, it's not a bad idea to make the effort to get a second opinion if possible. The COVID situation has made this televisits and teleconferencing much more common. But I will be very honest with you that I think there is absolutely no substitute for seeing a patient face to face. How they interact, how they speak, how they walk, uh, the facial expressions. It gives you a lot of information that a simple phone call or even a video consult cannot give. Uh, so I think if one wants a second opinion, I think the effort that is made by the individual to get an opinion and the effort the person who is giving a second opinion is able to put in to provide that opinion is definitely going to affect the quality of the opinion that has been obtained. Now, like in everything, there is an element of trust involved. It's understandable that patients with high risk disease and poor outlook might get a second opinion and they do not like what they hear, and then they go and get a third opinion and fourth opinion. And I'm saying this because I have given third and fourth opinions also. You might not like what you hear, you might not hear what you want to hear. And at some point in time, one has to draw a line and say, something, I have met and spoken to people who seem reasonable and they seem to concur in terms of what's going on. And maybe it's time to go on with whatever recommendations have been made. If you've got multiple opinions, some of which are very similar, but unless you have a medical background, they might seem different, and it just leaves people incredibly confused in terms of what exactly has been recommended.
What new treatments are on the horizon for multiple myeloma?
So myeloma has seen a lot of new treatments develop. The last new drug to be licensed was selinexor, which is an oral drug for patients who have failed to respond to 5 classes of drugs. It's got very modest activity and has a role to play in restricted situations. Another new drug that is on the anvil, clinical trials have been finished and licensure is awaited, but it's available on an expanded access protocol at a small number of places around the country. We have it called belantamab, which is directed against something called BCMA, the B cell maturation antigen. So it's an IV infusion that is given once every 3 weeks. So that's, I think, potentially an exciting new development. Obviously, a number of new CAR-T protocols are being developed in myeloma. There is a new drug called, I think it's called teclistamab, coming from um, uh, Johnson and Johnson or Janssen, which is a bispecific antibody. So bispecific antibody is really like a link. You know what they say about square peg not fitting in a round hole. And that is the phenomenon that prevents the immune system from attacking certain cells. And what BITE does, not unlike CAR T cells, is provide a link. So a BITE antibody has a receptor for T cells on one side, and for the malignancy, in this case with teclistamab, the BCMA B cell maturation antigen on myeloma cell on the other side. So you give the drug, and it forms a link between the myeloma cell on the one side and the T cell from the patient on the other side. So the T cell can attack the myeloma cell. So there are a number of different drugs that are on the horizon. Of course, I'm not mentioning things that have been around for some time, Implicity and Darzalex and so on. So one very exciting development for Darzalex, which is an extraordinarily potent and useful drug, with I think the broadest approval of any drug in myeloma, is that it is available, or it is going to be made available within the next few weeks as a shot or a subcutaneous injection, which can be given over 3 to 5 minutes, as opposed to a long infusion over several hours. And I think that's a real game changer in terms of ease of administration of the drug. So lots of new stuff coming out.
There were a couple of questions from participants around the medication bosutinib, and if the medication fails, what are the options for treatment?
So bosutinib or bosulif is one of the tyrosine kinase inhibitors used in chronic myeloid leukemia. It belongs to it's in the long line of drugs, starting with imatinib or Gleevec, dasatinib or Sprycel, nilotinib, ponatinib, and then bosutinib. The most recent member of this is called asciminib, which is in clinical trials now. And really, for chronic myeloid leukemia, the tyrosine kinase inhibitors, this whole spectrum of medications that I mentioned, is really the mainstay of treatment. There is a drug that was approved 8 years ago called Synribo, SYNRIBO, for patients who did not respond to tyrosine kinase inhibitors or were intolerant of tyrosine kinase inhibitors, with a very modest response. But bear in mind that in that 8 year period, another 2 or 3 tyrosine kinase inhibitors have become available. So I'm not sure that there is place for anything other than tyrosine kinase inhibitors in CML. And if there is absolutely no response at all, or if there is development of an accelerated phase or blast crisis, then it is worth considering stem cell transplantation from a donor. There are some interesting data in patients who have developed blast crisis, which is the transformation of CML to acute leukemia, where there is a combination of a drug called Vidasa or azacitidine, which is normally used in myelodysplastic syndrome, in combination with ponatinib, and that can result in excellent responses in some patients. So there is stuff available out there for chronic phase CML and also for advanced CML. So to go back to the individual whose options after failure of bosutinib, it depends upon what else has been tried, what the reason for failure was. Was it simple lack of response? Was it a lack of tolerance? Or was it development of one of these TKI resistant mutations and so on? All depends upon what has been tried.
Dr. Mehta, what do you think about RT cell therapy?
So, I think, again, the CAR T cells have been absolutely remarkable development in the treatment of malignancies, which can be appropriately targeted. At the moment, the most effective results have come in lymphoid malignancies, some of the B-cell lymphomas, a little bit in Hodgkin's disease, acute lymphoblastic leukemia, CLL, and multiple myeloma. The efforts using CAR T cells for myeloid leukemias, myelodysplastic syndrome, and other malignancies are being, the efforts are being made, but the results are very preliminary and somewhat modest, with some risk of off-target toxicity as well. So what the CAR T cells do is they have kind of like the bispecific antibody I talked about. Normally, the T cell is not going to attack the patient's own malignant cells immunologically. But if you modify the T cells and give it a weapon, a horn, if you will, to poke a specific target on the cancer cell, it can attack that cancer cell. But in order for the treatment to be safe, that target has to be unique to the cancer cell. If the target is present on other cells of the body, then those T cells are going to go and attack other cells of the body and cause toxicity. That is why there is a limitation in the diseases that can be treated with CAR T cells, because there are not too many malignancies which have unique targets on their surface. So CAR T cells have resulted now in long sustained remissions in diffuse large B-cell lymphoma, which I think is probably the single best application for them. For relapsed acute lymphoblastic leukemia, ALL, I think the results are good, but they are not lasting, and you can really use CAR T cells only to get a patient into remission, so you can proceed to a stem cell transplant. For other lymphoid malignancies, it's a work in progress. In myeloma, the results have been encouraging in the short run, somewhat disappointing in the longer run, because with follow-up, we find that the disease does come back in a lot of the patients, if not most patients. Uh, maybe we are using them too late. Maybe we need to use the CAR T cells earlier in the course of the disease. The problem, of course, is that these cells, this therapy is associated with a significant amount of toxicity. Sometimes it makes a stem cell transplant, a autologous stem cell transplant, feel like a picnic, even for the patient. And I know that there are people on the call who have had an autologous transplant, and they will know what I mean by that statement. And of course, it's very expensive. What is not? Which new medical treatment is not? So, do we use it early or do we use it late? I mean, those are questions that are open. So yes, I think CAR T cells are terrific, and like all powerful weapons, they have to be used in the right way, in the right patient at the right time.
For a patient that had to go off Revlimid, what are the usual treatments after Revlimid?
So, Revlimid was first used. We were the first actually to use. I had a patient that we started on a drug called C501, which eventually became Revlimid in early 2000. And for a year and a half, he was the only human being in the world to get the drug. He had myeloma, and he was about to die. He lived with Revlimid for another year and a half, and then then could get to the first Velcade trial that we were doing at Northwestern, and lived for another year and a half. So the first approval for Revlimid was in myeloma. So in myeloma patients who failed Revlimid, there's a whole bunch of options available based upon what treatment they've had previously. Now Revlimid is also licensed in a certain type of myelodysplastic syndrome, particularly something called the 5q minus syndrome. And if there is failure of that, then there are options like Vidasa, also called azacitidine. Revlimid is also approved for certain types of lymphoma now. And again, if there is failure of Revlimid there, then there are other monoclonal antibodies, new drug called polatuzumab, consideration of stem cell transplantation, and so on. So I think it all depends upon what disease we are talking about and what treatment the patient has had previously. But despite Revlimid being as potent as it is, relapsing from Revlimid does not necessarily mean that you are out of all options. There are plenty of things that can be done.
Well, I just wanted to remind everyone on the call to feel free to submit questions through the chat function. We do have a couple more that were pre-submitted, and then it looks like we have a couple streaming in. So I think we'll have time for those in the next 15 minutes. So just a little reminder. Dr. Mehta, how can a patient remain optimistic after a year has passed since diagnosis and treatments keep failing?
That's a tough one. It of course depends again on the disease and so on. But if all of us need hope to keep our optimism to survive. And if nothing is working, multiple things have been tried for a year. It is difficult. I think seeking a second opinion, seeking a frank discussion with the treating physician, perhaps seeking out a support group, like the Cancer Wellness Center and so on, where one might come into contact with other individuals and so on, may help. I think hope is critically important, but avoiding false hope is also critically important. I think it depends upon what disease we are talking about. I'll give you a simple example that sometimes patients with extremely low-grade disease don't respond well to treatment, but their life is in no danger. And patients with extremely high risk, rapidly proliferative disease respond extremely well to treatment and they relapse very quickly. So it's not simply lack of response, but what the underlying disease is that is important too. If the underlying disease is not life threatening in the short run, then one doesn't necessarily need to be too discouraged by lack of a great response.
Switching gears to transplants now, do you recommend re-immunization following a bone marrow transplant?
So, with an allogenic stem cell transplant, there is stem cell transplant from a donor when the immune system has recovered sufficiently, usually about a year or so after the transplant. It's definitely worth re-immunizing. After an autologous transplant, the question is not so clear. There are recommendations that re-immunization should be done. We do it sometimes, we don't always do it. Certainly, the seasonal flu vaccine should be given. The COVID-19 vaccine should be given when it is available. The Shingrix vaccine is worth doing. The pneumococcal pneumonia vaccines are worth doing. That's the Prevnar 13 and Pneumovax 23. But should childhood vaccines be given again or not is a controversial point. Sometimes in older individuals, vaccines can elicit adverse responses, and so I'm not completely gung ho about revaccinating every single autologous transplant patient. We do it on a case by case basis, but with an allogenic transplant, we certainly are a little more aggressive about re-immunizing patients.
So switching gears over to some of the questions that were submitted through the chat. We have a patient who has been in remission for a year and a half and had a splenectomy. Is she at a higher risk? Should she have the antibody blood test? She realizes she cannot donate plasma.
Well, obviously, we don't know remission from what. That the underlying disease will naturally determine, what their level of susceptibility to infections is. One thing is sure: anybody with a hematologic malignancy can never donate any kind of an organ or blood product. There is controversy about whether corneas can be donated or not. This particular individual is susceptible to bacterial infections by what we call encapsulated organisms, the prototype being Streptococcus pneumoniae, because they don't have a spleen. So, in patients who don't have a spleen or patients whose spleen might be compromised, we always give them antibiotics to keep on hand, not a prescription with a pharmacy, but a prescription that they fill. They keep the medication with them. They travel with the medication, and if they get fever, if they get a cough, if they just feel unwell, the first thing they do is pop one of the antibiotic pills and then seek medical assistance either from us or from their primary care physician or whatever. So for the individual concerned, I think there is the susceptibility because of splenectomy. Whether they should have a SARS COVID test or not depends. Now, I think the indication to test somebody who is without symptoms is doubtful at the moment. If you've got no symptoms at all and you just go ahead and randomly get a test done, a nasal swab, and you are colonized, what do? Do you go into quarantine for 14 days or 3 weeks? Nobody knows. And as far as the antibody test is concerned, there are some false positives and false negatives. So I think the antibody test is worth checking in certain contexts, but I would caution against getting random antibody tests done and making assumptions based upon that about whether one is susceptible or not susceptible. Bear in mind that there are four common coronaviruses which are responsible for common cold-like symptoms. And if you've been exposed to that and there is an antibody, there could be a cross-reactivity in any of the COVID-19 assays. Unlike a lot of or most rather, of tests that are done, which have undergone very stringent evaluation, the pragmatic approach that has been taken to try and accelerate development has resulted in products coming to market which might not necessarily be of the quality that we like. We accept it at the moment because of the critical nature of the situation, but when the dust settles, we are going to have to evaluate what is worth doing and what is not worth doing. For tests that are worth doing, which kits to use and which kits not to use, and so on. So I would be cautious about just randomly going ahead and getting a test done at the moment.
Yeah, and that kind of relates to another question that was asked here, and that's whether caregivers should get an antibody test, or if they even can at this point. It sounds like maybe not.
Yes, I think the same thing applies. I think a general rule of thumb, which I think is the safest way to approach it, is uh, consider yourself not immune, consider yourself susceptible. That's what I do. And consider any person that you are interacting with other than the immediate family, people that you know are okay, as potentially a carrier of the COVID-19 virus. And take appropriate precautions, maintaining the distance and wearing the protective gear and so on, and you'll be okay. Now, this is all well and good, but what about next month when things start becoming a little bit more liberal? I think that people like those on the call, even people like Carrie and Savina who come into contact with patients, and certainly physicians, have to be super careful more than we are now to make sure that we don't get exposed to uncontrolled situations where we might acquire something and then pass it on to somebody who is more vulnerable. 6 months or a year from now, the situation could be different because of availability of the vaccine, potentially availability of treatments, and there will also be a time when the level of infection and the so-called herd immunity in the population will have gone up significantly. So I think we are in for somewhat uncertain times at the moment for the next several weeks or 3 months or so.
Is a stem cell transplant the same as a bone marrow transplant? And could you explain that?
So stem cells are cells that give rise to more differentiated cells. You have the embryonic stem cells, which give rise to the entire body. And then you have organ-specific stem cells, the hematopoietic stem cells that reside in the bone marrow, that give rise to red cells, white cells, platelets, lymphocytes, and the lymphoid system, and so on. Similarly, there are neural stem cells, heart stem cells, and so on. So a so-called bone marrow transplant is a transplant of hematopoietic stem cells that have been extracted from the bone marrow. In the past, we used to collect cells from the bone marrow, and it was simply called a bone marrow transplant. And when we found out that we could trick those cells into coming into the blood and collect them from the blood, it became known as a peripheral blood stem cell transplant. But really, when you talk about a bone marrow transplant, you're talking about the anatomic origin, bone marrow versus blood. But the stem cells are the same stem cells. So if you say a bone marrow stem cell transplant, most accurately, we're talking about hematopoietic stem cells that have been directly collected from a bone marrow. And if you are talking about a blood stem cell transplant, you are talking about stem cells which have been mobilized from the bone marrow out into the blood and have been collected from the blood. So effectively, it is really the same thing. How you have collected the cells is different, and I think there is a big difference in the quantity of cells you can get one way versus the other way, and so on.
We have a question here that I think you addressed when you're talking about the COVID-19 testing, but we have a patient who had a stem cell transplant in February for non-Hodgkin's lymphoma and is going to Northwestern tomorrow for blood work, ultrasound, and a PET scan. So they wonder if they should get tested for COVID-19 while there.
I think if you are without symptoms, the simple answer is no. You may simply be an asymptomatic carrier of the PCR. And if you find out that you do have it, what are you going to do about it? And with the treatment for B cell non-Hodgkin's lymphoma, even if you've been exposed to the virus and have some element of antibody response to it, the fact that you have had a transplant recently as well as treatment for the B cell disease, I talked about Rituxan and the suppressed antibodies, you might not show any positivity. So I think until we know more about it, it doesn't make sense to get the test done. For what it is worth, I will tell you that neither I nor any member of my family have been tested either for the antigen or by PCR or for the antibody because we simply do not know what it means and what it would do to how we should go about our day-to-day business. If somebody were to develop symptoms, that's a different story. But otherwise, I think let sleeping dogs lie.
So we are coming up on 8 o'clock right now. I just wanted to ask if you had any final things that you wanted to share, any last thoughts before we close out the program.
No, I think it's great that we are having this dialogue, keeping up hope and optimism, and acquiring knowledge is important because I think knowledge is the best protection against worry and fear. But it's also important to get knowledge that is to some extent curated, to some extent verified, and to some extent credible. And right now, if you go on the internet, there's a lot of stuff out there which is not necessarily vetted and it might not be accurate. So it's also important to take everything with a little bit of, I wouldn't say pinch of salt, but always try and verify things. Don't automatically assume that things are true just because you've read them somewhere. And bear in mind that with the best minds and the best resources at work, we will be able to overcome the COVID-19 virus, and the advances that are occurring give plenty of hope for virtually all patients with hematologic malignancies.